I'm giving a talk. It sounds kind of odd for rheumatologists to give this talk, I think, but it sort of makes sense, I think, right? We like steroids, right? Well, we have a love and hate relationship with steroids in rheumatology. A running joke of rheumatologists is like, oh, aren't you just going to give them steroids anyway? We're in the hospital service, and I was like, well, let me tell you, rheumatologists steroids work right away, but our job is to try and figure out a better long-term management option that takes the place of steroids. Rheumatology has advanced so much. We're able to give, all these biologics that target specific parts of your immune system beautifully and work so great. But yeah, in the meantime, let's give them some steroids, right? So we know steroids works quick, right? And not all of our other drugs don't necessarily work as quickly. So steroids are still something that are utilized quite a bit. I think that there's a lot of excitement, and it's somewhat more recently, even in the last few years, people have been talking about the utility of steroids in management of certain infections. It made headlines, for example, with the COVID trial, right, using dexamethasone in COVID. So there is a talk about it. You think about medical dramas, okay, and you'll have a patient who is crashing, right? They're not doing well. They're getting hypotensive, and what's going on? We don't know what's going on. And then the resident will say, well, let's give them steroids. And then the attending will smash their hands and then say, no, what if it's an infection? You'll kill the patient, right? So it's this dramatic idea that steroids are going to really harm the patient. And, I remember when I was a first year fellow, I was seeing this patient who had small vessel vasculitis, and we thought they were active with glomerulonephritis, but they also had sepsis. They had a blood culture positive bloods, and we were working with the infectious disease doctors. They're on antibiotics. I remember I timidly called the infectious disease team. I'm like, hey, what do you think about what if we give them a little bit of steroids? It's like hesitant how they're gonna respond. And he's like, yeah, go for it. And I was like, what? I thought you like they're gonna put up a fight a little bit. Like we give steroids and septic shock, I was like, oh yeah, okay, fair enough. So that's what kind of really opened my eyes. Like, well, how big of a deal is this in terms of utilizing steroids in the setting of an active infection? We always think of it as a bad idea. So one of the things I want to emphasize up front, and I'll emphasize throughout the thing, I'm not saying steroids are like good for you and they're going to help infections. That's not the case, right? We know that long-term steroids increases the risk of infection. Patients on long-term steroids back in the day, before we had all these fancy therapeutics for autoimmune diseases, patients got infections quite a bit with long-term steroids, amongst all the myriad of other side effects that steroids comes with. But in an acute setting, I think there's clear evidence for their utility, and a whole lot of evidence that they may be helpful, and not a whole lot of evidence that they're actually too harmful in the short acting acute window of treatment. Okay, and what is surprising, I think, is just how far back people have been doing this. How long people have been utilizing steroids in the setting of infection, actually even before the time of antibiotics, which is going to be fun to talk about. We're going to look at some really old literature. It may not help you clinically, but it's fun. The second half will help clinically maybe a little bit, okay? But we're going to dive into some history first. The disclosures are consulting for these three companies that I'm giving a talk on ancient drugs, so no, nothing to do with these companies. So the outline is going to be kind of one of the interesting concepts of this is that, if you ask somebody, why would you give steroids now in the setting of infection, you might kind of get some hemming and hawing and say, well, maybe the hemodynamics of steroids are beneficial. Maybe if you have an overactive immune system that is like having neutrophils, they're eating up your alveoli. If you have pneumonia, maybe if you can stop that overabundant immune response while you let the antibiotics work, that could decrease morbidity and mortality of patients. But sort of interestingly, our understanding of steroid physiology changed, and that changed our decision making for when to use steroids in the setting of infection. I'll kind of hopefully make that a little bit more clear. Then we talk about discovery of steroids and its first use, the recognition of steroid risk of infections, early trials of steroids in infection, like why would they do this? Why would they give steroids in the setting of infection? Talk a little bit about the tuberculosis data, which is interesting, and then kind of end with kind of more organ-specific manifestations like meningitis, pneumonia, septic joints, septic shock. Okay, but to start with, let's talk about steroids and how they were kind of elucidated and how we figured out these molecules that rheumatologists love so much. So for a long time, the adrenal glands were much ignored. We didn't really know what to do with them. So they had these blobs sitting on top of the kidney that didn't really have any vessels coming out of them, but they're highly innervated. So they seemed like they were sort of important, but they weren't like transferring anything to anything because they didn't have any vessels. I mean, they didn't have any blood flow going away from them. People didn't really know what the adrenal glands were doing. There's even like a medical journal that put out a contest that said, if anyone can give us what the adrenal glands are doing, we'll pay you X amount of money. So there's tons of different people putting in ideas. They're all like very poetic and the evanescence of life and things like that. But no one really had any idea. These two people made a big difference in our understanding of this. You probably recognize the name Thomas Addison. Dr. Thomas Addison was a internal medicine doctor with a special interest in dermatology, who was working at a hospital in London, Guy's Hospital it was called. And he was trying to better understand causes of anemia and skin changes. So it sort of worked out pretty well for this. And he saw this collection of patients who had quote unquote anemia, general languor, and debility, remarkable feebleness of the heart's actions, irritability of the stomach, and a peculiar change of color in the skin. Okay. And he followed 11 of these patients and they died. And then back in the day, that medicine doctor went and did the autopsy. And in the autopsy, all these patients had like a totally wrecked adrenal gland, right? They're totally necrosed adrenal glands bilaterally. And so he hypothesized that maybe the adrenal gland is necessary for life because all these patients, they didn't have other clear morbidity, but they had wrecked adrenal glands and they all died kind of in a similar fashion, kind of lingered as he called it. The difference being in 70 to 80% of his cohort, they're all from tuberculosis. So tuberculosis was attacking the adrenal glands in all of these cases. One little side fact about this is Richard Bright, who's like one of the considered the fathers of nephrology, was one of these patients. His patient was in this cohort of patients with what's we now call Addison's disease. And Addison wrote this letter like, how did Richard Bright miss this diagnosis? Why did he not suspect the adrenal glands were involved when that wasn't even a disease yet? He's very mad at Richard Bright for missing it. So Thomas Addison put adrenal glands on the map as maybe they're somewhat important, right? We have these patients who died and they didn't have functioning adrenal glands. So then we got Dr. Charles Brown Sequard, who's considered someone says the father of endocrinology, but I think endocrinologists also don't like him too much because he did some pretty strange things later in life. He is best known for the hemisection of the spinal cord, causing the temperature change on one side and motor deficit on the other side, the famous Brown-Sequard syndrome. He did a lot of heavy lifting research-wise early on in his career. Towards the end of his life, in his 70s, he started doing some pretty strange things. He got really into testicular extract and grinding up testicles and injecting that extract into the skin and giving yourself vitality. So he'd probably be really famous on TikTok. That happened now, but it would be so back then it was then considered him a charlatan. So it sort of tanked his career and his how people thought of him. But before he did those testicular studies and suturing testicles on people, he got Thomas Addison's paper that said, hey, look, these adrenal glands seem to be kind of important. And he's like, well, I can prove it. So he got a whole lot of animals and then he dissected the adrenal gland out of them. And the animals all died eventually. And he argued it wasn't from bleeding. He would, do an autopsy after the animal died and show there was no bleeding. And the definite cause was the adrenal removal. So people argue back and forth, is it really that important? So then he got this sort of interesting study. He got those animals, took out the adrenal glands, and then transfused blood from an animal into that animal without the adrenal glands. So he transfused blood from a normal animal into the adrenal ectomized animals, and the animals survived. So he argued something is being produced from the adrenal glands that kept these animals alive. And you could give it to them by giving it the blood of another animal. So that's kind of a pretty good experiment. But it took a long time to figure out what that was and to objectively measure what was happening. So then we get to the dog studies. So Dr. Olivier was a doctor in the 1890s, and he was trying to better understand what the adrenal glands were doing, and he would get ground up adrenal gland and actually inject it into dogs. And he was found that it would actually raise the blood pressure of the dog, and it would actually raise the pulse of the dog. So something in it, and now we had an objective measure that the adrenal gland extract was doing something physiologic. So the sort of curveball in this story is that he knew injection had a physiological effect. He didn't know about eating it, so he actually fed adrenal gland to his child to see it, and then he measured their pulse to see if the pulse would go up, and it did not. So he argued like, oh, well, you have to inject it, you can't eat it. I don't know why he wouldn't do that for the dog. The dog would probably be happy to eat adrenal gland, but he gave it. One review said it's probably apocryphal, but it makes the story more interesting, that's for sure. And he did that. So you have to inject whatever the adrenal gland was making. So 10 years later, 1901, there was a Japanese physician who actually crystallized and isolated adrenaline. So that was the first compound produced by the adrenal gland that was discovered. It took another few decades to really start figuring out cortisol and the production of steroids. And I'm skipping a lot here, but I think one of the end results of this is really kind of an interesting story about how World War II played a major role in this discovery. So in 1941, there's actually rumors of German pilots taking adrenal gland extract to increase their resistance to oxygen deprivation and high altitudes. So the Allies were concerned that the Germans were much more advanced in their steroid knowledge, and they're making super soldiers with adrenal extract, or whatever the steroid was that the adrenal glands were making. So a lot of money started being poured into that research. And I'm going to give a first major tangent that has nothing to do with this talk, but it's interesting. So hold on. So the National Research Council set 3 major priorities for government-funded research for the impending war and for World War II. Okay? And these 3 are maybe surprising. Okay? So number 3 was the development of anti-malarial. So that sort of makes sense, right? So why does that make sense? So if we're suspecting that there may be a war in the Pacific, we knew that there was a lot of malaria in the islands. So they realized that malaria could be a major catastrophic problems if soldiers were sent to the Pacific and all these soldiers got malaria. So you might say, well, wait a minute, didn't we have anti-malarials at that time? Yes, we did. We had the bark of the cinchona tree. Okay, so that was known to be a good anti-malarial therapy using the bark, and we knew the actual active substance was a chloroquine. Okay, so they say, well, why can't you just get the bark of that tree and give it to the soldiers? Well, the reason was because the bark of the tree, or the trees, were mostly grown on an island called Java. And the problem with that is the Japanese took over the island of Java. So we didn't have, Allies didn't have access to the island or those trees. Another thing is the company who owned those trees were in the Netherlands. So they said, well, maybe we can get it from the Netherlands. We can get they maybe it was shipped over to the Netherlands and it was dispersed from there, but the Nazis occupied the Netherlands. So we had both sides occupying pretty key parts of anti-malarial therapy. So a lot of scientists came together and we started synthesizing chloroquine. So that was a huge triumph, and probably saved a lot of lives and a lot of morbidity during the war. Interestingly, a little anecdote here is that's also why we started using it in lupus, because you all might wonder, like, why on earth do we use anti-malarial for autoimmune diseases, right? This, like a lot of our drugs in rheumatology, is done completely by accident. So these soldiers who were fighting during the war, who happened to have rheumatoid arthritis or lupus, started feeling better. And there's lots and lots of reports of these soldiers coming back after the war and asking their doctors to continue giving them the anti-malarial therapy. Right? So that's when research started being looked into anti-malarial therapy. And it took decades after that to understand why it might be helpful. We still don't, I think, clearly know why they work so well as they do, but that's the reasons, because of World War II. The next fun little fact is this one makes a lot more sense, right? Development of penicillin. So we want to develop an antibiotic, and because people in the war have a wound, they can get infected. So making penicillin makes a whole lot of sense, right? You might be wondering, well, that's odd. Didn't we discover penicillin in 1928? So 1928 was when Alexander Fleming discovered penicillin. But it took that long to be able to figure out how to give it, which I think is surprising. So the first person to ever receive penicillin was in 1941, after it was discovered in 1928. It was Albert Axelrod, something like that. Is a 20-something-year-old police officer during the war. A bomb hit by, and he got shrapnel in him, and he got a staphylococcal infection. He was the first person to ever receive penicillin, because he was definitely going to die. Otherwise, he had an abscess behind his eye. His eye was removed. Brutal life, right? And they gave him penicillin all they had. They didn't have very much of it, and it worked great. His fever dropped. He felt better. His cultures went negative, And then they ran out, they couldn't give enough, and everything came back like a couple days later and he died. So the first person actually ever received penicillin died. Unfortunately, because they couldn't produce enough of it to make a lasting dosage. So that's kind of surprising. And then the number one priority by the National Research Council set for research funding during World War II was actually the isolation and production of cortisol. Okay? So that was the number one priority, which is sort of surprising. So it beat penicillin out of all things. And again, that was just because of that concern that steroids do something to enhance soldiers' abilities, which ended up not really being true. So then we get to the Nobel Prize in Physiology or Medicine in 1950. Okay? And this is because of the work of mostly Edward Kindle and Thaddeus Rechstein. He's the person on the left and the middle. They're the basic scientists who were really working on this. Dr. Edward Kindle was in Mayo, Dr. Rechstein was in Switzerland. And they were doing a lot of work on the adrenal gland trying to isolate cortisol, and they were successful. The sort of interesting story is this guy comes along, Dr. Hinch. And Dr. Hinch is really, really famous in rheumatology. In the rheumatology world, there's Hinch Awards, Hinch Talks, things like that. He was the chief of rheumatology at Mayo, where Kindle was doing his work. And he was trying to treat patients with rheumatoid arthritis. And he had this young woman coming in, really bad rheumatoid arthritis, and they couldn't make her better. So what was happening was Dr. Philip Hinch's theory was he noticed that some patients with liver disease had improvement in the rheumatoid arthritis. So he actually would give liver toxin medication to injure the liver in the hopes of helping rheumatoid arthritis. That's how desperate people were to treat this. Now they think, oh, rheumatoid, we can totally knock it out, right? But it's amazing, like this is pure desperation to help these patients. And it didn't work. So this young woman got really upset. She was young, she had a family, and she's reportedly refused to leave the hospital until she felt better. So Dr. Hinch was wondering what to do. And he thought the liver was producing something, and he called it substance X. And he didn't know what it was. He thought that must just be some weird substance in the body that decreased rheumatoid arthritis activity. So he went to Kendall, who knew he was isolating something from the adrenal glands, and said, "Hey, any chance this could be the substance I'm looking for?" And Kendall's like, "I don't know, maybe. Who knows?" And so he actually got it from Kendall and gave it to the young woman, who felt amazing. So it was the first time someone ever received cortisol for rheumatoid arthritis. And she reportedly went to downtown Rochester, Minnesota, the next day to go shopping. If you've ever been to downtown Rochester, Minnesota, there's not a whole lot there, so I don't think that would take very long to shop there. But it was that was the first use of it. So they all won the Nobel Prize. And it was also a time where you could win the Nobel Prize by just totally guessing, right? So you think that how hard it is to win a Nobel Prize now, but this guy was like, this patient has rheumatoid arthritis. I can't treat it. This guy is making something that I don't know what it is. Let's give it to her and see what happens. And it worked, right? You throw a lot of things to the wall and something sticks and you get a Nobel Prize for it back in the day. So Kindle and Reichstein did true work trying to figure this out. Hinch kind of guessed a little bit and it worked. And it totally changed the course of how we treat rheumatoid arthritis. But not long after, we started realizing patients started having side effects of steroids, right? People started getting infections. Steroids were pretty widespread, but early on, we started realizing they started getting cushingoid, gaining weight, the sugars went up, and it sort of we didn't know how to dose it, right? We were dosing all over the place. Even sort of surprisingly, even endogenous steroid access we recognized had a higher risk of infection. Looking at natural history of Cushing syndrome, for example, the majority of patients actually died of infection. So the idea that steroids increase your risk of infection was not new by any means, but the problem is we didn't really have any other answers. So one thing now you might be wondering, well, why on earth would we use steroids to treat an infection then, right? Where would that come from? And that came from some odd sources. So this is a couple quotes from these papers that use steroids early on in treatment, saying, many studies on the pathology of the suprarenal glands have lent support to the theory advanced 40 years ago that the suprarenal cortex detoxifies, probably by its lipids, not only metabolic products, but also bacterial toxins, and also protects the organism against bacterial invasion. So there was this thought for a while that the adrenals produced something that inhibited bacterial growth. That being probably wrong, but it's one of those things that the reason that it was is because they had this experiment where they would give typhoid to rats, and then if the rats had their adrenals intact, the rats would tend to live longer. And if the rats had no adrenal glands, they tended to die faster. So that seems like that would probably make sense, right? But it was like, but they kind of associate that, oh, that's because the adrenal glands must be attacking the typhoid somehow, not the fact that the adrenal glands just kind of help hemodynamics. So that was kind of this false assumption that is highly associated with the immune system, the adrenal glands. So those early studies kind of gave us the false identification that adrenal glands were important for the immune system. So because of that, however, we actually get treatment. We actually get therapeutic trials of giving steroids in the setting of infection. 1932, so this is half a decade before penicillin, even before sulfa antibiotics were given. The first published case series of patients with infections, typhoid fever, undulant fever, which is probably brucellosis, postoperative erysipelas who were given cortical extract. So we didn't have cortisone at this point, but they just got the adrenal glands and injected it into people. And there's 5 patients, all of them responded great, except the one who died. So they said like, it's just like the one, it's like, oh, by the way, one patient died. So they kind of are flippant about it. But I guess the point is that these patients seem to do pretty well, except for the one that died. Right? But it's sort of, I think, surprising people too that we were actually using steroids directly to treat infections even before antibiotics were. That's not, I guess, not totally surprising if you're completely desperate and you don't have antibiotics yet, right? And then 1940, so we have sulfa drugs at this point. So we have suprarenal hormone and salt in the treatment of pneumonia and other severe infections. We have Cortin administered 2 to 5 cc's twice daily, intramuscular or subcutaneous for 2 to 3 weeks, cases. 17 cases of bronchopneumonia, 1 case of malaria, and 6 cases of the old grippal infection, right? Whatever that is. So you can see that a lot of these trials are very different than things that are run today, where they kind of like lumped all the infections together, right? And kind of mixed them in a bag and see what would happen. So trials like this wouldn't be done today, but that's what they did. They kind of lumped infections as one entity and threw steroids at it. You also see throughout these trials that I show a huge variability in the type of steroid and the dose of steroid used. So the steroid kind of dosage and types are all over the place, which is sort of true today. Still, we still don't know the dose or the type perfectly. If you ask 10 rheumatologists what dose of steroids you're gonna get, you get 10 different answers, but a very strong answer about it. So the dosing is all over the place, so I probably wouldn't focus too much on that. So 1 death occurred out of 17. The authors note the following: maintenance of normal blood pressure with prevention of collapse, decrease in evidence of toxicity, avoidance of distension, increased sense of well-being, and apparent shortening of the period of convalescence. Okay, so these authors were all about this. They were pretty excited about how patients responded to this Cortin injection. One thing, sort of, they don't really define what they mean by toxicity, for example, but one thing sort of pans out even in more recent trials is this apparent shortening of the period of convalescence, which you'll see kind of pop up more and more. Here's another trial, again, 1950, which is sort of surprising because they didn't use antibiotics, even though we have antibiotics at this point. And this is looking at streptococcal sore throat infection. And this one actually have some objective measures that were being kind of monitored for these patients, sort of, which is like chilliness, right? That's an objective measure listed here. We have headache, malaise, sore throat, exudate, enlarged cervical nose that were noticed in these patients who were given cortisone, okay, and it was a strep infection. And you'll see that these lines don't really separate. So we have the empty circle as control and full circle as cortisone. So this is one of the first trials where they actually had a control for it. And you'll see not a huge difference, right? Not much difference in large cervical nose, not much difference in exudate or chilliness, right? It was pretty similar. The conclusion was cortisone exerted no effects on the symptoms or physical signs of this infections. So again, not a whole lot of excitement about what it was doing, but you can see one thing that's kind of consistent is that there wasn't a whole lot of concern from a lot of these papers that steroids were making people worse, right? Either that it didn't do a whole lot, or it was actually maybe a little bit helpful and help people recover quicker. So one thing sort of interesting is, the look of the history of tuberculosis. And this is a paper from 1950, 59, and it's kind of summarizing what we knew about the use of steroids in the setting of tuberculosis. And at that point, we had streptomycin, which really kind of revolutionized our treatment of tuberculosis, our first antimicrobial that had activity against tuberculosis. I think we had PAS, and I think we had isoniazid at this point. And they were trying to see whether or not steroids could be helpful. So why were they giving steroids in setting infection? Well, a lot of studies looking at patients with severe tuberculosis recognized that they said they had consistently low 17 keto steroid levels. And they were worried that these patients with severe tuberculosis may have some degree of adrenal insufficiency at the time of their infection. So the thought was, well, maybe if we give steroid, these patients will do better. So we had these patients on streptomycin, they had streptomycin plus steroids, and the people got sort of impressed that the patients people thought they did better. Streptomycin, by the way, tended to people got resistance to it pretty quickly. But people thought that when they were getting steroids at the same time, they did a little bit better. Here's a patient who came in who had failed all three trials. He got PAS, he got streptomycin and isoniazid, and he came in with a fever. And you see the fever here curve, and then all this, he got Stirain, which is this type of prednisolone here, and the fever kind of drops. So they're arguing here this patient got better once they finally got steroids. They talked about, you can't really see very well here, the row integram, as they called the X-ray, showed improvement in the X-ray once the patient had prednisone administered. So this is another example of prednisone administered with improvement in the X-ray. So I liked the conclusion this patient makes. I think it's sort of apt today. The end of this paper, this review said they, which are steroids, can be a life-saving in many acute forms of tuberculosis, only when these drugs are used judiciously. That is, the minimum dosage for the shortest period necessary to obtain the desired effect, are complications diminished. These findings illustrate the paradox that a powerful drug can produce disastrous results when used where indicated, and yet produce a beneficial result when used where contraindicated, but wisely, right? So it's a little tricky to follow that logic, but he's giving examples. It's kind of paradoxical to use a steroid during infection, but if it's used with some thought behind it, it could potentially be beneficial to these patients. So, that's 1959. What do we think about it today? There's still a role for open evidence still says there's a role for for steroid therapy in certain types of tuberculosis, but I think most of the data is promising for tuberculosis meningitis in particular, where steroids are given, and it seems to be less enthusiasm for like pulmonary tuberculosis or tuberculosis pericarditis, for example. But you can see back in the day, people seem to be pretty excited about it. Granted, you had a whole lot less options for treatment back in the day. But then, so that was, the thought, like maybe the adrenal glands were helpful for the immune system. That turned out not to be true. Maybe everyone with that infection was adrenally insufficient, probably not true. So our understanding starts to evolve, and we start having improvement in our design of clinical trials, okay? So the next big probably evolution and understanding of steroids and why they may be beneficial in a setting of infection is the hemodynamic impact of steroids. And what that means is because they first noted that when you had an adrenalectomized animal, the animal would become hypotensive pretty quickly. And they called it the vascular collapse. Right? So they're trying to better understand steroids' effects on the vasculature. And I think that these are some of the early trials looking at combinations of epinephrine on vessels. So they have, this is ex vivo, so they have mesenteric vessels that are perfused or strips of aorta, and they're kind of be measuring their contractility to different stimuli. And these patients were all the vessels were getting stimulated with norepinephrine or epinephrine, but then when you added steroids, you actually see kind of this big spike start appearing on the strip where the vessel is contracting more. So that kind of led to the idea that, oh, well, steroids are actually probably doing a whole lot more for the vasculature than we think. And again, that kind of, put a lot more enthusiasm for why we might be using steroids in setting up, for example, septic shock, right? When the patients have the quote unquote vascular collapse, that maybe steroids would be beneficial in this patient population. So the other big change in our understanding of why we might use steroids in the setting of active infection is our understanding of immunology got better. Our understanding of chemical messengers within the immune system got improved, such as cytokine physiology, right? So we start realizing that maybe there's there's a morbidity associated with infection from the overabundant immune response. When you don't have antibiotics, you probably want that overabundant immune response, best chance of keep you alive, right? But in the setting, if you have antibiotics to help with that bacteria, there's potential for the eager immune response to have a negative impact on the outcome because you have neutrophils eating up your alveoli, for example. So they started thinking that, okay, so now we have this, we have IL-6 through the roof, we have all these cytokines through the roof. Maybe they're part of the problem, and if we tamper these inflammatory cytokines down, you may produce a better result. So this is kind of where we are kind of now, right, with our understanding of why steroids could be useful in the study of infection, probably from a hemodynamic standpoint and an overeager immune response standpoint. So I'm going to jump a little bit. So now we have this new understanding of hemodynamics, a new understanding of immune system. What do we know at this point? 1974. So this is a list of all the literature on steroid use of infections from 1950 to 1971. And if you can't see it that well, I can tell you there's a whole lot of studies, and 2 of them seem to have a harmful effect with the use of steroids. The rest of them either had no effect or were considered actually beneficial in the outcome of patients with an acute infection. Again, this is in the setting of using an antibiotic as well. Sort of interestingly, the one that is one of the 2 that's mentioned as harmful is actually pneumococcal meningitis, which we now use steroids for, right? So, so that didn't hold up very well. So one of the 2 definitely is out. But I think that it shows there's probably more data than you think there is in the use of steroids in the setting of active infections. So now we're kind of switch gears and kind of focus more on organ specific. And we're going to talk about pneumonia. We're going to talk about meningitis. We're going to talk about a septic joint. And we're going to talk about an end with septic shock. Okay. And I think that this kind of helps. I think it's a little bit more clinical applicable. And I'm going to kind of focus a little bit on some of the animal models that led to the theory of why this might work. The first one doesn't have an animal model, though. The 1956 study in pneumonia, hydrocortisone upon the course of pneumococcal pneumonia treated with penicillin. 113 patients, single-blinded control study. They found that quicker symptomatic improvement and greater comfort during the acute phase of the disease, no shortening of time to complete restoration of well-being. It said that, quote unquote, it is clear there was no worsening of infection by hydrocortisone and the incidence of complications of steroid administration was negligible. That's 1955, 56. Right? Then more recently, you probably all know, we have this trial, 2015, 785 randomized assigned double-blind placebo-controlled, 50 milligrams of prednisone daily for 7 days in the setting of community-acquired pneumonia. And it showed a primary outcome of time to stable vitals of 3 days versus 4.4 days in placebo. And the study showed a reduction in hospital stay by 1 day and a reduction in the requirement for and duration of IV antibiotics. Adverse effects was more hyperglycemia in the hospital, which, you're dying of pneumonia. Insulin is not too big of a deal, right? So again, we have pretty good studies in pneumonia looking at this, and I think that's really changed management of pneumonia and community-acquired pneumonia. Okay. So the Cochrane review says that more recent Cochrane review says corticosteroid reduced mortality and morbidity in adults with severe community-acquired pneumonia. The number needed to treat for an additional benefit outcome was 18 patients to prevent 1 death. Corticosteroid therapy reduced morbidity, but not mortality for adults and children with non-severe community-acquired pneumonia. Okay? So things are looking good from a pneumonia standpoint and steroids. Okay. Meningitis, this is a different beast, right? So we have, we're thinking about that immune response in the lungs, for example, or the neutrophils are eating out the lungs. But in the meningitis is a very different picture because it's a closed system, right? Where if you have inflammation within that closed system, you have brain death, right? You have the swelling inside the brain. So that sort of makes sense early on that maybe steroids would be beneficial in this setting. What you may not know is we actually have data from the 80s that clearly show a benefit here. And actually, it's one of the only studies that I know of that compared 2 different types of steroids. So we have an animal model where the animal was injected in their CSF with pneumococcus, I think it was. And they got meningitis. And then they had these arms where they would get no treatment. They would get methylprednisolone or they'd get dexamethasone. Okay. And then they'd look at the outcome was what happened to the pressure in their CSF, what happened to the CSF lactate, what happened to the white count, what happened to the bacterial titers. So bacterial titers show no major difference between these groups. But look at the change in the CSF pressure, right? So no treatment is plus 7.5. Methylprednisolone didn't do much better, plus 7.8, but dexamethasone had plus 1.8. So you see a major difference between either methylprednisolone and dexamethasone in the amount of pressure change in the CSF of these rabbits with a meningitis. You even see a pretty big difference in the number of CSF lactate, 75 versus 43 in the dexamethasone group. So that's kind of what put the spotlight on dexamethasone use in meningitis was this animal model back in the 80s, right? And then we get the famous 2002 dexamethasone in adults with bacterial meningitis. 301 patients followed up for 8 weeks. Outcome measures were unfavorable outcomes based on the Glasgow Outcome Scale. And you'll see that, unfavorable outcomes were seen in 26% of patients in the dexamethasone versus 52% of patients with the placebo. So a pretty big difference. And the largest improvement we're seeing in patients with infective pneumococcal meningitis. So, and dexamethasone did not result in an increased risk of adverse events. So this was a big deal, right, when this trial came out. I think subsequent trials haven't been as dramatic for the use of dexamethasone. I've heard there's some controversy of its use in meningitis, but if it was my brain, I would take the dexamethasone based on that rabbit model. It really made a difference. Okay? So then we have septic joint. So I think this is really surprising to people that we actually have data on the efficacy of steroids in septic joints. I think from a rheumatology standpoint, it's one of the big nightmares, right? When you have what you think is gout, they have a big swollen knee, they have a history of gout, you drain fluid and say, oh, it's probably your gout again, and then you inject that knee, like, oh, I feel good about myself. And then the lab calls you a few hours later, there's a gram-positive organisms in that CSF, out of that synovial fluid, like, oh no, right? So the worst, the thing in our head is to inject steroids into an infected joint, right? So we actually have data on this. And importantly, up front, it's really important to know you have a septic joint. So I don't want to leave here saying, oh, steroids for septic joint is a good idea. The only reason you know you have septic joint is if you drain the fluid. So you have to drain the fluid first, right? So critically, just injecting someone with steroids or just giving them steroids with one big swollen joint is probably not a good idea because then you don't know they have a septic joint until much later. So discovering septic joint is critical in this algorithm here. Right? So we actually have a rabbit study. Okay, the rabbit had staph epidermidis injected into their knees. Okay, and not surprisingly, that rat knee got really big and swollen. The rat couldn't move around. Okay? Oh, rabbit, sorry, not rats. And they had three groups: control group, only infected, versus infected and treated with antibiotics, and infected antibiotics plus intra-articular steroids. And they killed all the rabbits a few days later, and they did histology, and they found that the best looking histology actually was in the rats with the injected knee, with the injected steroid. Okay. So they actually looked like maybe in the rats that showed an improvement, right? So what does that mean for humans? Okay, so there's no study looking at injecting a human with septic joint with steroids unless it's done probably accidentally. So, but we actually have some oral steroids, and we actually have pediatric studies looking at this. So in 2003, a double-blind randomized placebo-controlled trial of 123 children, 61 assigned to dexamethasone, 62 to the placebo groups, and they evaluated the end of treatment at 6 months and 12 months. And the outcome here was just joint dysfunction. Like how well could the kid move their joint after they had a septic joint? Right? After they're treated, antibiotics, they may have had surgery. And they found that at 6 months, dexamethasone had 1 residual joint dysfunction and 19 residual joint dysfunctions in the placebo. At 12 months, dexamethasone was 1 residual joint dysfunction and placebo had 13 residual joint dysfunction. So pretty dramatic, like actually how much joint dysfunction the kids without the dexamethasone had compared to the kids who got oral dexamethasone. But that's not all, folks. There's more trials. So randomized controlled, double-blind, placebo-controlled trial, 49 patients between the age of 6 and 18, dexamethasone or antibiotics versus antibiotics alone. And this has a whole lot more outcomes, like first day of fever, less than 37, no local redness, no local heat, first day of full range of motion. And you see these two arms, like first day of range of motion is 12 versus 7, pain-free is 10 versus 7, then redness 3 versus 1. So kind of across the board, you see some improvements in the dexamethasone group. And the conclusions for this is a 4-day course of dexamethasone given at the start of antibiotic treatment in children with septic arthritis is safe and leads to a significantly more rapid clinical improvement, shortening duration of hospitalization compared with the treatment with antibiotics alone. So then we have sepsis, okay? And I have a pendulum on this one, right? Because there's dozens and dozens of trials. This could be like a week-long course. I'm just going through all the trials of this. And it's kind of like, you can see like the history of this. Like you'll see the 1960s, people were all about giving steroids and septic shock. The 1970s and 80s, like, ooh, this might be a bad idea. The 1990s, like, ooh, this is a good idea again. It went back and forth, back and forth. The data got better and better and better, but there's still a lot of confusion about what to do in septic shock. But the animal models are pretty persuasive, okay? So the animal models from 1980s was looking at baboons who were given E. coli, okay, intravenously. Not good for you, right? And group A was given E. coli only. Group B, that's the one to pay attention to, got steroids and antibiotics plus the E. coli. And group C got antibiotics alone. So they got E. coli plus antibiotic without the steroids, okay? And you'll see that they got kind of different dosages of different things, but it's pretty dramatic. It's not subtle. So all the people, all the baboons who just got E. coli died. 19 hours. E. coli is pretty efficient. Killed them pretty quick, okay? Group C, who got antibiotics plus the E. coli, all died, but it lasted a little longer. They held on, okay? So it lasted 24 hours. Whereas Group B, all of them survived who got the steroids plus those antibiotics. So, if you look at animal models, this looks great, right? It's pretty black and white. It's not so black and white in humans. We can save a lot of baboons, but in humans, it doesn't work so well. So this is one of the earliest studies, the VA, a lot of really important VA studies from the 60s and 70s. This is one of them. Randomized, controlled, double-blinded, high-dose glucocorticoids, 172 patients. This is looking at the amount who died. So on the steroid group, 10% died. In the saline group, almost 40% died, right? In sepsis. And they also have a retrospective section, which is somewhat similar, okay? So what was the thought process then? Well, we're not so sure. Actually, quite a few studies throughout the 80s. And they started saying, well, it looks like things are sort of favoring the controls, right? So this is when some early studies from the VA look promising. In the 80s and 70s come about, like, maybe not. These other studies are not as favorable, but we get better at designing trials. We get bigger and bigger studies. We have more what's the word for it? Consistency with how septic shock is treated. So these trials start getting better and better and better. So do we have an answer? Not so much. So this is a HYPRIS trial that came out looking at people who have sepsis but had not gone into septic shock yet. They want to know if they have sepsis, could you catch them early and give them steroids before they became hypotensive? And the answer was it didn't seem to work. So giving the steroids early on did not seem to work in these patients and reduce the chance of septic shock. Again, pointing out this was not showing harm with the use of steroids, though. This is some of the more recent data. Adjunctive glucocorticoid therapy in patients with septic shock, hydrocortisone versus placebo. No change in patient surviving, but hydrocortisone group showed more rapid resolution of shock, 3 days versus 4. That seems like good, right? And time to discharge from the ICU was shorter in the hydrocortisone group, 10 days versus 12 days. So that's also pretty good, right? That's actually one less day in the ICU is a lot of money too. Then we get adding fludrocortisone. Remember how I was kind of say we just kind of throw different types of steroids and see what sticks? This is one of them. So hydrocortisone plus fludrocortisone for adults with septic shock. You actually see a split here, right? Actually, some potential evidence of better outcomes and probability of survival. So this is showing, this is again some of the back and forth, and this is a more recent Cochrane, keeping in mind those big 2018 studies. Concluding, we demonstrate that corticosteroids probably reduce mortality, increase shock reversal, and decrease SOFA scores, which is one of the septic shock scores in patients with sepsis. Corticosteroids probably increase hypernatremia and hyperglycemia and may increase neuromuscular weakness. Dose response meta-analysis shows a different dose. So this is like saying, yeah, maybe it works. I asked colleagues of mine in ICU, like, what do you guys do now? What's the thought process? And they're these long answers. Okay, so it's not clear still. It's like, well, it depends on okay. So it's still not clear how useful steroids is in the setting of septic shock, and it changes from decade to decade, it seems. But I think one thing is pretty clear is that all these studies have shown not a clear worsening of infection with the short-term use of steroids, right? This big bugaboo of giving steroids in the setting of infection isn't necessarily the worst thing you could possibly do, and it may actually help the patient. In fact, we probably have more trials demonstrating the safety of steroids in the setting of active infection than there are harms. We actually look at, back-to-back trials, as long as the underlying infection is being treated. So the big problem that we see is that, like vasculitis, when we see patients who thought they had vasculitis, they gave them high-dose steroids, got rituximab, they got worse and worse and worse, and it ended up being, endocarditis mimicking active vasculitis. So when you miss the infection, that's clearly bad. You're not actually treating the infection. There's no doubt the steroids are not going to be good for that patient. But if the treatment is adequate, then it seems like steroids could be beneficial and necessarily not harmful in many situations. Hopefully in a short duration, a short amount of dosage. So we walked through a lot of history of adrenal gland, maybe more than you ever wanted to know. And then we talked about how glucocorticoids were linked to infections and how even before the advent of antibiotics or discovery of antibiotics, people were using steroids in certain types of infections. You have a long history of, you actually have a longer history of treating infections with steroids than you do antibiotics, believe it or not. And then you say the changing landscape of why glucocorticoids were used, and I focused on, meningitis, pneumonia, septic joint, and septic shock.